Risk is really evaluated based on where's the location of the tumor. Has this recurred in a previously resected or previously radiated area? Is there numbness or tingling, which is a trademark of perineural invasion? How deep is it? How big is it? Is it attached to skull? Is it attached to bone? Is it attached to muscle? Location, is it on the eye? Is it on the lip? You know, you've got to look at where it is with respect to functionality of organs, and that's where you determine the risk. Most people think that head and neck squamous cell carcinoma and CSCC are interchangeable. However, they're very, very different. CSCC originates from the skin. It happens from sun damage, has a high mutational burden. Squamous cell cancer of the head and neck is usually a consequence of smoking. So it's, again, a toxin-related injury. But most of these tumors are also associated with viruses like EBV and are managed very differently. They don't have the same high mutational burden that cutaneous squamous cell cancer does, and they do respond differently when it comes to immunotherapy. Looking at this case, it's a very complex case. As I had said before, everything is potentially resectable depending on the surgeon that you talk to. The question is it the right thing to do? You've got a lady who has a lesion on her lower eyelid with perineural invasion. When it comes to resectability, could it be resected? Sure, it could be resected. However, the extent of the surgery that would need to be done is pretty extensive, and she would need a skin flap, and again, you'd want to make sure that the perineural extension doesn't go all the way back into her skull where you leave disease behind. So that has to play a role in how you decide whether this is a resectable lesion or not. Her comorbidities, the hypertension, the hyperlipidemia, 99% of Americans have that. What 99% of Americans don't have is rheumatoid arthritis. Is rheumatoid arthritis an exclusion criteria for immunotherapy and cemiplimab? The answer is no. Do oncologists need to be astutely aware that these agents are going to exacerbate that underlying autoimmune disease? Absolutely. And so what I routinely do before I start any of my patients who have RA on immunotherapy is touch base with their rheumatologist. Make a plan ahead of time. Be prepared that these agents, although they will provide control of a squamous cell cancer that has the potential to be disfiguring or life-threatening, is really going to exacerbate their underlying joint pain or their rash, depending on what their autoimmune issue is. And just be prepared to be able to work with the rheumatologist to control the pain for those patients so that they can be comfortable and still receive the therapy that they need.